Good evening and welcome to our first Healthy Women, Healthy World educational gathering in 2022. My name is Stacy Helm, and I'm a volunteer member of the Healthy Women, Healthy World team. If you are new to our group, welcome. We're thrilled that you have joined us. If you're a Healthy Women, Healthy World veteran, we are so happy to be with you again. We are all volunteers committed to learning and mobilizing champions for women and children impacted by global health issues. We gather quarterly for free educational events just like this one. We are supporters of Medical Teams International, a humanitarian organization providing life-saving care to people in crisis. Our topic today is timely and very close to my heart. My MSM project was to identify and assist in setting up a nutritional program at a clinic in Guatemala City. One of our speakers, Amy Boxtotler, opened my eyes to the issue of malnutrition and was a mentor to me along the way. Guatemala is a beautiful country in Central America. It's about the size of Kentucky, but with a population of 15 million people. It has been deeply affected by a civil war that lasted for about 36 years, from 1954 to 1996. Guatemala is also among the 10 countries that are most vulnerable to natural disasters and the effects of climate change. These two facts have affected the country in many ways. 46.5% of children under the age of 5 in Guatemala are affected by stunting, and it can be as high as 70 and 90% in the hardest hit municipalities. Stunting is a sign of malnutrition that leads to a vicious cycle of malnutrition, more stunting, and poverty. This is one of the highest prevalence of stunting in the world, as well as the highest in Latin America and in the Caribbean. All three of our speakers bring so much insight and knowledge to this topic. I can't wait to learn from them. By now, you are more than familiar with Zoom. Tonight, we're using a webinar format. Your audio and video features are not available. Please use the Q&A feature at the bottom of your screen at any time during the program to ask questions of our presenters. We are streaming this webinar on Facebook Live and also recording it so that we can share it with those who are unable to join us. Finally, we value your input as we continue to improve our virtual events. We love it if you take a minute to complete the short survey that will be available at the end of our program. We like to begin our events with a moment of reflection to focus us away from our daily distractions, to calm and turn our minds to being together, to share and to learn. I'd like to share a prayer written by Reverend Gail Song Bantam, who is the lead pastor of Quest Church in Seattle. For all those who are confronted by seeming boundaries, limitations, and impossibilities, this is a psalm reminding us of who God is and God's holy otherness and God's holy withness. A psalm of possibility. God, creator, hoverer, you speak and we form. You breathe life and we awake. You said it is good and we believe, God. The Red Sea before us, shouting impossibility. They say we can't, we shouldn't, and we wouldn't. Words seeded from our youth, the limits and the lies. There must be truer truths in us to confound, resist, defy. Created from nothing, said something, made everything. This God. The Lord will fight for us, so we need only to be still. Still our souls, stand out loud, trusting that God is El Roy, God who sees, bears witness to a name, at her sound, leaps, demands possibility. Emmanuel, God with us, for us, within us. God, you said it is good, and we believe. You breathe life, and we awake. You speak, and we form. God, creator, hoverer. We are so fortunate to have three experienced and insightful presenters tonight. Amy Britton and Dr. Walter Lopez each bring different perspectives, responses, or solutions to our discussion tonight. They will each introduce themselves in greater detail. Our first speaker is Amy Boxtotler, a dear friend of mine, a nurse, a missionary living in Guatemala for the last 6 years. It is my pleasure to welcome and hand off to Amy.
Thank you, Stacy. It's an honor to join you all tonight here from Guatemala City. As Stacy said, my name is Amy, and I've been serving here in Guatemala as a missionary nurse for the past 6 years. My nursing experience in the States included pediatric nursing, and I have a master's in community health nursing. Malnutrition here in Guatemala is something that I see often, and so I do appreciate this opportunity to share with you more about this prevalent topic. There are many factors that cause malnutrition here in Guatemala. Many families struggle from day to day just to make ends meet, and that has been true since before the pandemic. So you can imagine how much harder it's been during the pandemic. During the next few minutes, I'll introduce you to some of the challenges that families face in both urban and rural settings throughout Guatemala and how those challenges contribute to malnutrition. I'll also share with you some ways that I've been able to help fight malnutrition and what I've learned from those experiences. As we move to this picture of Guatemala, you can see it's a beautiful country full of mountains and volcanoes with fertile land for growing food. The country of Guatemala touches both the Atlantic Ocean and the Pacific Ocean and has amazing spring-like weather year-round. But it's also subject to many natural disasters such as earthquakes, hurricanes, and landslides. The capital of Guatemala is Guatemala City, and as you can imagine, it is a large city. There is a lot of diversity within the city, and you can see areas of high rises and large malls. And then there's other areas of the capital city that are kind of slum-like areas with no running water. People that live in rural areas of Guatemala often want to move into the capital city so that they can look for jobs and have a better way of life. And there we can see the picture of Guatemala City, so you can see how big and expansive it really is. So now I want to take you to a specific community within Guatemala City. This is a community of over 10,000 people who are living around and working in the Guatemala City garbage dump. In this community, people aren't getting paid to work. They're actually scavenging through the garbage dump to find items to recycle, items to clean up or resell, or items just to use in their own homes. Here you can see one of the streets within this community that's around the garbage dump. And this is the community where I've been working in a clinic and serving the people that live here. Not all of the streets look like this, but many of them do. As families come into this area, they typically start squatting on the land, which is going to mean dirt floors and poorly built houses. The areas that they first move to will have no running water and no bathrooms, which, as you can imagine, makes life extremely difficult for the families that are living there. Here you can see one of the new areas that's being built up and just the piles of dirt that the houses are sitting on top of. As we move to the next slide, you can see that with time, parts of the community do improve a little bit, but most families are still living in poverty. As you know, poverty often increases crime and gang activities, which is also true in this community. Unfortunately, the cycle of poverty is hard to break, and children living here have a very difficult life. Now I want to take you out into rural Guatemala, where again, you can see how beautiful the mountains are. And with that, it brings very remote villages. In kind of the middle of the picture, if you can see some white dots in the middle of the mountain, you can see a small village. Not all the villages are quite so remote. but many are, and many other small towns are hard to access. The families that live in these villages work primarily as farmers, and they have an incredible talent for growing crops on the side of a mountain. And although beautiful, life in the rural areas can be difficult, and access to a variety of foods can be a big challenge. The main group of people that live in rural Guatemala are the Mayan Indians. There are actually 22 Mayan dialects, and in many villages, the Mayan dialect is the first language, and then Spanish is learned once children start to study in school. In the rural areas, it's more likely that the males will finish school, and the females might start school, but after a few years, they're required to stay home and help around the house. This has resulted in many Mayan women being illiterate and only speaking the Mayan dialect with a limited knowledge of Spanish. From this picture, you can see the traditional clothing that is worn by women and girls, and most of this clothing is woven by hand. And this tradition of weaving is learned from the time that children are young. In the next picture, you can see this sweet girl that is learning how to weave. And she's doing that so that she can help her mom to sell items in her store and help carry on the tradition. She was very excited when we stopped in to show us what she was working on and show that she was helping her mother. Women in Guatemala work very hard. Many families live without electricity and running water. Clothes are typically washed by hand and hung out to dry, and cooking is done over a wood-burning stove. All of these things require a lot of time and energy, including gathering water and wood day after day. In this picture, you can see a lady making traditional Guatemalan tortillas. Making tortillas involves gathering the corn, letting it dry, taking it to the mill to have it ground, and then mixing the ground corn with water and making the tortillas by hand over a fire. Tortillas are a main staple in the Guatemalan diet and typically eaten with every meal. They are a cheap way to fill some hungry bellies. So now I'd like to introduce you to Ana. She is a Mayan woman who moved with her family from a rural area into Guatemala City, and they settled into the community around the garbage dump. Her husband died, leaving her a single mother of 6 children. In this picture, you can see her 2 youngest. Her sister does live with them, which means there are 8 people living in a very small and cluttered home. Ana goes into the garbage dump every day to work and tries to make enough money to buy food and provide for her family. She has learned some Spanish from her kids, but her first language is Mayan dialect because she never had the opportunity to go to school. When Ana was pregnant with her youngest daughter, she did not have the healthiest of diets, nor during the time she was breastfeeding, which means that this sweet baby has had poor nutrition for her entire life. As I think of Ana's situation, I can only imagine how overwhelming this must be for her, as she faces so many daily stresses, such as being a single mother, going every day into a terrible job, living in a dangerous community, trying to provide clean water, food, washing clothes, and trying to keep her kids in school. Ana herself has never been educated on eating healthy or what to feed her kids. So after a long, stressful day of working, she feeds her family what is the cheapest and easiest to fix so that they aren't hungry. In Guatemala, those staples are often tortillas, black beans, and rice, which those foods in and of themselves are not terrible, but it's the main thing that kids are eating day after day with very little variety. For her and many other mothers just like her, there is little ability to provide any more than those basics, and she has little to no knowledge that she should provide any other type of nutrition. Ana's situation shows us how the problem of malnutrition is multifaceted. Just a few of those problems are lack of education, lack of knowledge, a lack of money, a lack of resources, and a lack of support. Because of all of these different problems, I wanted to find a way to help begin to fight malnutrition. With Stacy's help, we were able to start a nutrition program and provide a bag of a powdered nutritional supplement every month. The supplement gets added to a child's food or drink every day and is the equivalent to giving them a daily multivitamin. At the beginning of the program, we took the child's height, weight, and their iron levels. And then we asked families to come back once a month and pick up a new bag of the supplement and receive some education on proper nutrition. And then every 6 months, we would take the child's height, weight, and a new iron level if it had been low. Thankfully, we were able to see improvements in weight and height and iron levels in 95% of the kids that were taking the nutritional supplement and returning to the clinic every month. There were lots of factors out of our control, but we saw this as a huge success. The mothers started seeing the importance of coming every month as they began to see improvements in their child's health. They began to tell us that their kids were eating better, they were sleeping better, they were more active, had fewer respiratory infections and less diarrhea. What I loved most about the program was the one-on-one conversation that I was able to have with the mothers and see their desire to learn more and provide better nutrition for their families. Sadly, here in Guatemala, there are cases of neglect that lead to malnutrition. But from what I've seen, many families do love their children and are concerned about them when they start to show signs of malnutrition, but they lack the knowledge and the resources to know how to make any changes, which is why it's so important for us to be empowering families, especially mothers, to know how to provide better nutrition for themselves and their children. So that's a little bit about my experience with malnutrition in Guatemala. And now I would like to turn the time over to Dr. Walter Lopez, who is the Medical Teams International Country Manager for Guatemala.
Thank you, Amy. Good evening. It's an honor to be here today with you. As Amy was saying, my name is Walter Lopez. I am the country manager for medical teams in Guatemala, and I was serving here for the last 8 years. Thank you. Please, the next slide. Yeah, medical teams in Guatemala is working since 2010, implementing maternal and child interventions to reduce chronic malnutrition. Next, please. To start, I just want to highlight the fact that malnutrition has many adverse consequences for the maternal and child population in Guatemala. According to the evidence, malnutrition comprises both undernutrition, which includes stunting, underweight, wasting, and micronutrient deficiencies, and overnutrition, which includes overweight and obesity. Malnutrition negatively affects all aspects of an individual's health and development, which at the end limiting the economic and social development for the society in general. Undernutrition reduces the body's capacity to resist and fight against diseases. And the immediate consequence or effect is the high rates of infectional diseases. Anemia during pregnancy is also causing preterm low birth weights and developmental delays in children and increase women and children mortality. Just to say that the burden of malnutrition in Guatemala is impacting not only the health, but the opportunities for developmental capacities in this population. Next, please. According to the United Nations International Children's Emergency Fund, UNICEF, the malnutrition as a condition, as a medical condition, a public health condition, is very well known. And there are, as you can see in this slide, there are at least some different layers of root causes and for malnutrition. And it's very important to understand them, because that allows us to design and implement comprehensive interventions to tackle and reduce the burden of malnutrition. As you can see at the bottom of this figure, most of the root causes are related to policies, economic, and institutional capacities. For example, in Guatemala, the Ministry of Health is responsible to provide health services, nutrition services, and other different preventive programs to reduce malnutrition. But they are not accomplishing their goals. As a consequence, the families, especially mothers who are responsible to take care of the health of their children and families at household level, are not having enough information or education on how to feed and how to prepare properly food for their families, especially for children. And the immediate consequence is the inadequate care for mothers and children, the insufficient health services, and unhealthy environment as well. And that produce in the population inadequate dietary intake and a lot the special infectional diseases. And at the end, the result of the outcome of these root causes, it's malnutrition and high rates of death in maternal and child population. In medical teams, we are working to address some of these root causes, as I will show in the next slides. Next, please. Just to share with you why malnutrition is prevalent in this population in Guatemala. According to most recent statistics, 51% of the population are living in rural communities in poverty without any basic services for health, education, or sanitation services. In Guatemala, only almost the half of the population are having access to clean water and improved latrines, and most of the families are cooking inside home with open fires. The lack access for health services is prevalent also in Guatemala. For example, in average, we only have 3 health professionals per 10,000 people in rural areas, when the standard from the Pan American Health Organization is 25. So there are some families that they never seen a medical doctor or a professional taking care of their health at the community levels. The fertility rate in women in Guatemala is also high. According to the statistics, there are 4 births per woman still in Guatemala. And as a consequence, the maternal mortality rate is very high, one of the highest rates in the Latin American country. During the pandemic, only 24% of the population are having access to COVID-19 vaccination, which is threatening the life from those populations in the community, in the rural communities. And the last year, we were impacted, especially the rural communities were impacted by 2 hurricanes. And that left the families in a very high risk of food insecurity and as a result, malnutrition. Next, please. As I was telling you, medical teams is working in Guatemala, serving in Guatemala in rural communities. And since 2013, we are serving in different rural communities in one area in Quiché, in the very remote villages where the population I described before is living. Based on the root causes of the malnutrition, we designed, in partnership with Providence, the government, the Ministry of Health, and the communities, we designed a program with 2 main objectives. In the side of your screen, you see objective 1. For us, it's a component. It's a list or group of interventions to improve the health status of pregnant and lactating women and children under 2 years. Why them? Because they are the most affected population by malnutrition in these communities. To address this goal, to achieve this purpose or goal, we are trying to tackle the diseases, the prevalent diseases in children and mothers, especially pneumonia. Pneumonia is the first cause of death in children under 5 years in Guatemala. Diarrhea is the second cause of mortality, but it's the first cause to produce malnutrition in this population. Underweight, as I was mentioning before, the conditions as they live, the mothers they live, the pregnancy conditions are providing low birth weights, and underweight is a very prevalent issue in Guatemala, and the lack access for maternal and child health care services. So we are trying to tackle these situations, implementing different interventions, as I will describe later in this presentation. We are also providing sanitation conditions through 3 different community projects, like properly latrines or ventilated latrines to reduce open defecation and sanitation to the communities, rain collect water systems to the families, and we also are implementing ventilated stoves to reduce the pollution and contamination inside homes. In the other side, we are also supporting the provision of health services, supporting the Ministry of Health. We are providing supplies, basic supplies to the Ministry of Health. We are providing training to their health staff, and we also, in support with Providence, we implemented some health facility infrastructure projects in 20 health facilities. Next, please. For now, in the second cycle of programming in Quiché, in Chicaman, we are serving 1,110 families in 20 communities. As I was mentioning before, we implemented those numbers of community projects to increase or to improve the well conditions for the families in those communities. During the pandemic, we play a key role supporting the Ministry of Health, providing equipment, the protective equipment for them, providing training on the protocols and how to address the situation of the pandemic for COVID-19 in Guatemala. And we also are working with different community leaders or volunteers at the community level. We are mobilizing the population in favor of the health for mother and children at the community. You can see the budget we spent during the fiscal year 21. This is for just 1 year to implement the different interventions I was mentioning. Next slide, please. I just want to share here with you with some pictures what we are doing in the field. How is the practical interventions we are implementing? As you can see here in the below in your screen, we mobilize or we organize some community groups at the community level to measure and weigh the babies under 2 years every month, with the purpose to identify early identification for those underweight children, in order that we can train the mothers, train the families, and provide some methodologies in how they can improve the nutritional conditions for the babies. These sessions happens every month by our staff in coordination with the Ministry of Health and the communities. As you can see in the picture, those are community members trained by the medical team's staff to conduct the growth monitoring sessions. We also are educating the families with several topics related to maternal and child health, how to reduce diarrhea, how to manage pneumonia, how to seek the health services when they are facing some complications, for example. And this educational process is implemented by a group called Mother Counselors, which are women from the communities selected by the communities, trained by medical teams to provide education to other mothers in the communities, home visits and follow-up to the families with are facing those challenges. As you can see here above, you see the toilets, the latrines we are providing to the families that reduce the contamination of the environment, providing sanitation and dignity to these families. Water is very important for health. We are promoting hand washing, using of clean water, but that cannot be possible if we are not providing the resources to them. That's why we are implementing rainy collection water systems for these families. And this is not also a collection, but they are learning how to treat, how to purify the water they are consuming in order they can reduce the burden of the infectional diseases. We are implementing also ventilated stalls with the purpose to reduce contamination, pollution for children under 2 years at the community level, and that reduce the prevalence of pneumonia as well. And as I was mentioning before, we are providing support to the Ministry of Health. The investment of the government in the health system is very low. According to some statistics, the government is only investing no more than $80 per year per person in the health system, which is not enough. So most of the time they are having issues with the resources. And we are also providing training with the support of volunteers from Providence in technical aspects. Next, please. What we have achieved in this time, I want to share with you some successes we are seeing in this program. For example, the antenatal care increased from 22% to 52%, which is important because the health providers now are providing vaccination, micronutrient supplementation, antenatal care, education to the pregnant, and nutritional education to these pregnant women as well. Now they are receiving, the pregnant women are receiving micronutrients, which is important, as I was mentioning at the beginning. Anemia, for example, it's a leading cause of maternal mortality. And we are providing, in partnership with the Ministry of Health, iron from 57% to 70%. Almost close to almost 100%, I can say, are receiving folic acid, which is very important during a pregnancy, for example. Now, the population are going to the health facilities more often because they know, they learn the relevance to receive the different services for mothers and children. And the Ministry of Health now is well equipped to provide the health services to them. Mothers are learning, or they learn how to consume, properly nutrition food during their pregnancy. So their behaviors are changing as a result of the education process at the community level. The children were with low weight when they birth also reduced a little bit, but this is a trend. We are happy because we are impacting in this issue. Next, please. We also reduced the underweight children from 20 to 18. So maybe 2% can be a very small difference, but for children, it's an important difference, and for the families as well. We reduce also a little bit the stunting children. This is a very hard indicator to reach because reduced chronic malnutrition takes time and takes another intervention, sustainable interventions. not only by us as medical teams, but the Ministry of Health, the communities, and other governmental and non-governmental institutions as well. But we are seeing a reduction in this problem. We are providing micronutrients to the children, and this is very important. The diarrhea decreased from 43 to 22%. As I was saying, diarrhea is the leading cause of malnutrition in children under 2 years. Pneumonia is the first case of the first cause of death in children. So we are reducing pneumonia in a significant way. Hand washing is a very important public health intervention, and we are teaching to the families and providing the clean water. So now they are increasing the practice of hand washing. As you can see, almost for me it's important, or it's amazing when I went to the field to talk to the mothers and see how they are practicing hand washing. Just because they have water, they have the hand washing stations, and they know they have learned how to practice hand washing. They are using a proper latrine now. The often defecation has reduced. That increased the sanitation conditions for the families at the community level. And they are receiving health, nutrition, and hygiene education each month by the group of volunteers at the community level called the Mother Counselors. Next, please. And just to share with you some very inspirational stories. Here is Marcela Cal. Marcela Cal, it's a lady who is living in a rural community in Chicaman. And she was telling to us that before the project, before the water system, she had to walk 2 hours to get a little bit of water, not a significant amount of water, just per one day, for example. And they had to stay there in the spring water like by 3 a.m., just waiting to collect a little bit of water. And the water, it was not enough to practice hand washing or to consume clean water. So we implement the project with her family, and she said that everything has changed. In her own words, everything has changed since they have the water system, because it's close to is in her home. So now she can invest the time in other activities with her family. And as a result, her children are drinking clean water. And as she said, they get sick less of diarrhea and other diseases at home level. Next, please. This is another story I want to share with you. She's Rosario Home. She was pregnant. She doesn't know that she will be having twins. And of course, she faced some complications at the community level, but she received support from the different community volunteers, organized and trained by medical teams and Ministry of Health at the community level. And she received the services they deserve. She was referred to the health facility, and at the end, she's alive, and she's enjoying those beautiful babies. Next, please. I was saying that with the storms the last year, or the hurricanes the last year, and the pandemic, now the population in Guatemala is struggling with different issues. According to the humanitarian response plan created the last year by different organizations, including medical teams, we are working with the cluster for the humanitarian response in Guatemala and in Quiche also. The needs are increasing for these families. For example, according to this plan or the research this group conducted, almost 50% of the population are living in poverty, and 18% is living in extreme poverty. Extreme poverty is where they live with less than $1 per day per family. So they are having several issues in the economy status. Food insecurity is another challenge for us in Guatemala. 3.5 million of people are in need in different communities, including the communities where we are working. 1.8 million of people require humanitarian assistance after the hurricanes. In the area where we are working, there are some communities that they are not recovered yet from the impact of these storms. They lost their crops, they lost their houses and other resources they have, and not having enough economy. So you can imagine the challenge they are facing in these communities. 2.2 million of people, indigenous people, are in need, lacking the access for health services, for example. 4.5 million of children and adolescents were affected by COVID. The schools were closed. Now they're returning, but they are having issues with education as well. And 40% of children are in chronic malnutrition or at risk of chronic malnutrition as a result of these events, natural disasters. Yeah, there's a lot to do still in the communities. We are doing our best. Thank you to Providence, to our colleagues and medical teams, to the different donors and other people who are supporting our work here in Guatemala. But there is a lot to do. So what else can be done? First, I would like to request your prayers for those families in need. Tell to others about this problem for partnership. We will appreciate your support to this type of programs. You can volunteer with us or with your contributions, and we will use those your resources to continue reaching more families at the community level who are in need. Visit the program. Come anytime. You are very welcome to Guatemala and learn more about what we are doing, what is necessary to do, and in partnership, we can do more for these families. So after this, I would like to present a very dear colleague and friend, Britton Gray from Providence. Britton, over to you.
Thank you so much, Dr. Walter. It is a great honor to follow Amy and Dr. Walter Lopez, both profound humanitarians, giving the best of their energies to advance essential nutrition programming in Guatemala. Likewise, it is also an honor to be with you tonight. Each person on this call represents a community of care and goodwill. Some of you I have traveled with and served alongside, and some of you I'm meeting tonight for the first time, but I'm no less grateful for the ways that you fight to make our world a better place. My name is Britton Gray, and I'm the Executive Director of the Global Domestic Immersion Program at Providence. Providence is one of the largest not-for-profit healthcare systems in the US with 52 hospitals across 7 states, and we have global partnerships in Guatemala, Mexico, Malawi, Uganda, and Nigeria. Before joining Providence 7.5 years ago, I had lived in Asia and Latin America, working for educational institutions and nonprofits. And one of the 2 years I spent in Guatemala was on the ground directly with Dr. Walter and his team. Within Providence, I've continued to work closely with medical teams as a part of our enduring partnership. And tonight I'm excited to zoom out briefly to the global context we're living together, zoom in to celebrate the powerful achievements of medical teams' work sponsored by Providence, and close by asking how each of us can deepen in partnership to advance health within our one shared world. We live in a time of mutually exacerbating catastrophes. We have a global pandemic layered with crises that are also economic, threaten food security, destabilize housing, and promote political polarity and hypernationalism. During this time, we know that 31 million people have been shifted into extreme poverty because of the pandemic, and global routine child vaccine coverage, among many different health indicators, has been severely disrupted. Of course, these are just a few examples. I think we have never had a moment in our lifetimes where the call to global solidarity has been stronger. These times of great challenge like ours call us to deconstruct silos and to strengthen in partnership. And I have never been more grateful than I am in this moment for the partnership between medical teams and Providence. And I always think about this quote from Dr. Paul Farmer, the founder of Partners in Health, who says, with rare exceptions, all of your most important achievements on this planet will come from working with others, or in a word, partnership. Providence sponsors programming year-round operated at the local level by medical teams, and we engage people of Providence in solidarity and service beyond borders through this partnership. By engaging employees of Providence, we extend our healing ministry, cultivate bidirectional exchange, and foster global citizenship. Medical Teams has been a flagship partnership with Providence since we began working in Guatemala in 2012. And since 2014, we've sponsored the Maternal and Child Health Initiative in Chicaman, El Quiche. Simply put, I would say the top priorities of our work are really to reduce the key killers of children under 2, health challenges as simple and as complicated as diarrhea, malnutrition, and respiratory disease, and also to improve maternal access to quality care. Advancing nutrition requires attention to interacting and mutually supporting illnesses at the community level. Around the world, diarrhea is a leading cause of malnutrition in children under 5. And as we know, diarrhea decreases appetite, it limits food consumption, it decreases the absorption of nutrients in the body. Children who die from diarrhea frequently are experiencing underlying malnutrition that made them more vulnerable to diarrhea to begin with. And with each instance or episode of diarrhea, that malnutrition is worsened. Diarrhea, as with undernutrition or malnutrition, also increases the likelihood and severity of pneumonia. And together, diarrhea and pneumonia exacerbate malnutrition. So we know within this, there is a critical cycle and relationship. Each of these individually are risks, but combined and in relationship, they layer their attack on the most vulnerable. As described by Dr. Walter, Medical Team's multilateral response directly tackles this complicated concern. Through targeted public health initiatives like what we see happening in this photo, community health workers from Medical Teams provide key education on each of these concern areas, supporting community capacity for recognizing danger signs, addressing symptoms, and breaking the cycle of illness. We see this in some of the vital data that Dr. Walter referenced, cutting diarrhea rates by half, reducing pneumonia rates from 29% to 3% in children under 2. These are huge advances. But social and behavioral change in the community and in our own communities is not only advanced through education, it is also access to the right tools, key assets to actualize learning into action. Which is why Medical Team's model of adding community level education by ensuring in-home infrastructure in addition to that education, such as improved latrines, water catchment systems to ensure clean drinking water, hand washing stations, access to soap, clean burning stove. These are all essential additional layers that complement education and promote culturally relevant behavioral adoption. Through this next photo, I'm excited to introduce you to a powerful community leader, Elisa, who I worked with years ago. Elisa was a volunteer mother counselor with Medical Team's community empowerment model. As a madre consejera, Elisa worked with Medical Team staff and was trained in critical health modules, which she then replicated to her neighbors and encouraged them to utilize not only what they had learned, but the key tools available that we see here. Beyond the doorway, you might be able to make out Elisa's latrine, and outside is her hand washing station with a bar of soap. These are simple tools, but they represent huge interventions in a world where we have more cell phones than adequate toilets. As we think about the latrine, the hygiene supplies, the clean burning stove we see here that replaced the fireplace Elisa previously used inside her room, her living room, her dining room, her kitchen, all in one. Between these two photos, we see critical tools that Elisa has in her hands to reduce risk factors and improve health for her family. And she was ecstatic about these elements being brought to life and what she was able to produce and change for her family and for her community. At times, when we talk about statistics or data, it can be possible to lose sight of human dignity, of resiliency, of the powerful passion of the individual member of the community for making a difference. And these are features and factors of who Elisa is. She is someone who is a leader in her community, motivated for change. So I want to be sure to balance any comments of crisis or recovery with the recognition of human resiliency, the power of community leadership, and the commitment of community members on the ground. In times of health crisis, effective intervention happens at the level of neighbors helping neighbors. And this is a tremendous power within medical teams model. Medical teams' approach to nutrition programming, just as with other aspects of their Quiche initiative, builds on core community strengths. Providence is proud to support this work because medical teams actualize as a community empowerment and community capacity building model that honors the leadership, the heroism, the strengths and resiliency, creativity, drive, and service orientation of the individual community members, like the mother in this photo. Through the community health worker model, community leaders not only dialogue the pitfalls and obstacles to health, but they also mobilize and actualize the solutions for sustainable change. And it has been a tremendous opportunity as Providence to learn from the families and leaders of Chicaman throughout the years of this program. Since 2012, more than 700 Providence employees or Providence caregivers have volunteered with medical teams within health system strengthening work, with the Ministry of Health alongside Dr. Walter and colleagues, or in the community with families constructing water catchment systems, improve latrines, clean burning stoves. Opportunities like this to walk in action-based solidarity alongside the community and Ministry of Health members has impacted our own organizational understanding of population health and also of rural healthcare delivery. And this is exemplified to some degree in this quote from one of our volunteers who noted that her service learning trip to construct water systems influenced her understanding of ways to deliver holistic healthcare to a community. Our medical teams and Providence joint work is, I think, an example of public-private partnership that is multi-layered and deeply impactful. Medical teams is an incredible partner for hospital systems or corporations looking to contribute and invest in international work. This partner sets a high bar, and here's why. Their work is steeped in subsidiarity, which within our Catholic social teaching within Providence is a term that talks about decision-making happening at the local level by those most impacted. That necessitates local ownership, which is what we see within this program. Also, we see a solid commitment to monitoring and evaluation, not just outputs, but measuring that impact over time, demonstrating change, and tailoring programming for greater and deeper impact in the years to come. Medical teams is also focused on sustainability by hitting a variety of levels at once, from that health change within the community to capacity building and capacity sharing at the clinical and Ministry of Health levels. But beyond corporate sponsorship or hospital partnership is also the daily support that folks like you and me also give to these causes. And so I'll close this section with this slide, which shows one of the largest games of Duck, Duck, Goose you will ever see beginning to gather a large circle of the community. Each of you here tonight, and myself as well, we are here because we care about our broader world. We are actively promoting and entering into a circle of compassion that leaves no one out. And my hope is that as we deepen in education, we also accelerate in action, whether through our time, our skills, or our donations. As global citizens, we all play a part in health for a better world. And the question I always want to return to is, what more can we do together? With that, I'll pass back to medical team staff for our Q&A section.
All right. Thank you, Amy, Britton, and Dr. Walter for sharing your knowledge and expertise with us. We are now moving into our Q&A time. If you haven't done so already, please input your questions into our Q&A section. All right. This first question is for Amy. What percentage of your efforts in Guatemala are directly related to malnutrition and its effects?
Yeah, that's a good question. I think I would say probably half of my time in the clinic is spent working with children and mothers and issues related to malnutrition. Yeah.
Wow, that's a lot. Okay, the next question is for Dr. Walter. Dr. Walter, what is one of your biggest accomplishments in this past year?
Yeah, that's a good question. I think the continuity of the program. As a result of the storms and the pandemic, we experienced some delays or some issues to continue implementing the program. But at the end, as a medical staff and health staff, we decided to continue doing our best effort to continue implementing the interventions. As a result, we only paused the program for no more than 2 weeks. After that, we redesigned the interventions, the strategy. We train our staff in biosecurity measures and the community volunteers, for example, and we continue implementing the program. I think for me, that is the most important achievement in the last year.
Wow, that's wonderful. That is quite an accomplishment.
Thank you.
Okay, I think the next question can be answered by anyone. How do you build trust to introduce proper nutritional and medical care with mothers who may never have had medical care themselves?
Yeah, I think I can answer that question. You know, for us as a national staff, we are part of the communities. Actually, our staff, some of them are coming from those communities, right? So they speak the local languages, they know the context, the culture and everything. And as part of the cycle of programming in medical teams, we normally visit the communities prior to implement an intervention. We have meetings with the leaders, with the families, just to have a common agreement about the problems they are facing, how they understand the situation. And we just propose the interventions. And in partnership with them, we introduce the program, the interventions. Our staff speaks in their languages. So I think the confidence is the way we create the confidence with the families.
That's wonderful. We do have a question asking, could you please define stunting?
Yeah, you know, stunting is low height for age. So it's when you see like a child in the communities with 5 years, and they are very, very low in their stature, for example. And that is the failure of the children to reach their full growth potential as a result of long-term poor diet, health, and care services.
Okay. With 22 Mayan dialects in rural areas, how is nutritional education provided?
Yeah, sorry to take the answer, but yes, as was saying, our staff, actually all of us, speaks one of the local languages. In the 20 communities where we are serving now, we have Quechua speakers, Pocomchi speakers, Quiche speakers, and Achi speakers, and Spanish speakers. And we normally select our staff, or one criteria to select like our staff is that they can speak one of the local languages. And the education is in the local languages because the rates of literacy are very low. We normally implement sessions without any letters. So we just run our workshops. We are very contextualized and different participatory methodologies for the education.
Wow, clearly a lot of thought goes into that. Thank you. And then we have a clarifying question. Dr. Walter, did you say the government only spends $80 per year per person on health measures?
Yes, it's correct. Regrettably, Guatemala is having the lowest investment in health, in the health system, in the region, in Central American region, for example. $80 per person per year to implement different programs. It's very low.
Wow. How has the COVID pandemic impacted these critical nutrition programs, and can they recover?
Yes, as I was mentioning before, yeah, definitely safety and security for our staff is very important for us. So when the pandemic impacted the country, we decided to stop. We were working at the office level, but part of our values is we are courageous, right? In medical teams, we are tenacious, and we are not alone. So we were at the office and we say, we are health staff. We need to go back to the communities to continue our interventions and try to support the Ministry of Health and the communities to face the pandemic. And we work in partnership with our colleagues in Portland, in Oregon, with our colleagues there. We develop the protocols to provide safety and security to our staff, to the volunteers at the community level. We identified immediately the needs for the Ministry of Health. They were lacking a lot of training or protective equipment for them in Chicamana especially, and we developed like a plan, right? So we invest from March to September in the 2020 to be prepared, right? To tackle the situation at the community level. After that, when we ensure the conditions, we reassume the activities for the maternal and child program. And now we are implementing the intervention.
That's wonderful. Does medical teams work with other organizations and NGOs that also work in Guatemala to coordinate efforts and work in more areas?
Yes, we work in partnership with different different levels. Especially our first partner or main partner at the community is Ministry of Health, because they are providing directly the health services. Yeah, but in the area where we are working before the pandemic and before the hurricanes, there was no other organization working, international organization working in that area. That's why medical teams and Providence decided to implement this program there. After the pandemic and after the hurricanes, a few organizations now are present in the area. So we are coordinating with them, the efforts. And we also participate in different clusters, like the humanitarian cluster of organizations in Guatemala, and with the nutritional organization in Guatemala also. Yeah, and we are trying to have more coordination and identify some partnerships with them in order we can scale up the program. That is one of our hopes.
That sounds great. Britton, this one's for you. Do you have plans to expand the Providence partnership with medical teams into further communities in Guatemala?
We are working right now very closely with Dr. Walter and Trina and other members of the medical teams staff at HQ and also in Guatemala to think about what is next within the program. And so we're actively evaluating a proposal, working together as partners, thinking about how we can enter into a new phase. We are wrapping up this year within our current program cycle and very excited to start a third. So we're in dialogue, we're in collaboration, thinking about what the possibilities are and what that could be, but very excited about the possibility of extending into new communities and replicating this phenomenal work that Dr. Walter and his team lead.
That's so exciting. Britton, this next one's also going to be for you. What is the most encouraging program that Providence is developing in Guatemala right now? And maybe you already answered that, but if there's anything additional.
I would say what I just mentioned in terms of that proposal, we are very excited about what the future holds in that. I would also add that And I think this is another aspect of how collaborative medical teams is as a partner, that Providence has another small partner layering in within some of the same communities where we're working right now. And medical teams has been very collaborative in thinking strategically with them. They are working on aspects of nutrition as well, thinking about family gardens, thinking about animal husbandry programs around chickens and producing protein for families that don't have access to protein otherwise. And we've seen, even within some of the monitoring and evaluation that medical teams has done, some potential impact from that program as well. And so we're really excited about all that this program holds in terms of nutrition, and then other layered efforts that could get at some of the other aspects and causes of malnutrition that Dr. Walter explored within that phenomenal diagram. Obviously, a very complicated landscape within nutrition. And so as much as we can do to address different aspects of that through dual or layered programming, we are very interested in doing so.
That's wonderful. And this next question will be for Amy. Amy, how has COVID impacted the communities that you have worked in within recent months?
Yeah, so in Guatemala City, a lot of the communities shut down during the pandemic. The garbage dump was closed to people going into it officially. And so it really took most everybody out of work. And people were sick and, poor hospital systems. So it's been a difficult time. I think people are recovering a little bit, but, we saw just a lot of effects of, not having work. People were having to, stand on the streets and wave a white flag saying that they needed help and needed food. And so thankfully, as a clinic, we were able to provide, some basic necessities for people and try to help them out as much as we could. But everybody, when you're living day to day and you can't work for one day, it really is a huge impact on your family. So.
Wow. Okay, we'll do one last question here before we move into our wrap-up time. Oh, there's so many good questions. If the Guatemala programs received a substantial investment exceeding the current budget, what would be the priorities for scaling the programs?
Yeah, thank you very much for that question. For the last 8 years, we were implementing those interventions and we are seeing good results. So we believe that the strategies, the interventions we are implementing are effective to reduce malnutrition or the drivers for malnutrition in these communities. If we receive more resources, there are a lot of vulnerable communities in Guatemala, not only in the area where we are working, but in other departments like Alta Verapaz, Huehuetenango, and San Marcos, who are having the same or worse indicators. So we are trying to get some resources, new resources to scale the interventions we are implementing now. We are conducting assessments and evaluations of what we're doing, and we are learning a lot and we can improve what we are doing, but definitely there are some other areas in critical need, especially after the hurricanes and the pandemic in the Western Highlands of Guatemala.
All right. Well, thank you everyone for all your wonderful questions. We can't thank our speakers strongly enough. Amy, Britton, and Dr. Walter, thank you so much for sharing your time and your valuable insights with us. Thank you to everyone else for attending. We truly hope you found this event informative, encouraging, and worthwhile. We'd love to see you again. So please mark your calendars and join us for our upcoming Healthy Women, Healthy World events. Our next book club will meet virtually March the 16th. We'll discuss Love Undocumented, Risking Trust in a Fearful World by Sarah Cazeta. That also has a Guatemalan tie-in. Our next educational event will be in April. We'll explore the world's growing refugee crisis and its toll on women and children. the turmoil in Africa, and how Uganda is becoming a beacon of hope. We'd also like to invite you to Medical Team International's signature event, Field of Dreams, on June 4th. This event will include both an online and live auction, dinner, and speakers. We are excited to gather in person again on the field of T-Mobile Park. Finally, we will be holding our annual summer movie in July, and we'll share more details about that soon. Watch for a follow-up email tomorrow with relevant links and suggestions for ways you can take action. And as mentioned earlier, you will receive a short survey at the conclusion of tonight's program. We value and appreciate your comments. We thank you for coming tonight and hope to see you at future Healthy Women, Healthy World events. Good night.